Yeah, we are starting the third session of this teaching program. During the last two sessions, we had classes on pain manage regarding the pain basics, the pain pathways, regarding the pain assessment, the scoring, and the importance of pain assessment as well as the hearing to the patient. And today we have the session. The topic is enhancing communication skills, wherein the learning outcomes will be barriers in communication, breaking bad news and pollution, anger management. We have a very eminent faculty with us to take this session. That is Dr. Biju Raghavan. He is the senior consultant and HOD the Pain and Palliative Medicine Department at Rajagiri Hospital, Alua. He is also visiting faculty at TIPS Trivandrum, as well as he works as a faculty in MNJ Institute of Oncology and RCC Hyderabad. Also, he's a faculty, visiting faculty at Department of Philosophy with the Kerala University, Trivandrum, and Rajagiri College of Social Sciences, Ernakulam. He's practicing palliative care since 2013, long, 17 years. And he's not 17, yeah, 20 years almost, yeah. And he belongs to the first batch of the 2-year PG diploma program in pain and palliative medicine. And his main interests are communication skills, oncology and respiratory palliative care, and end-of-life care. So, welcome, sir. And over to you, Biju Raghavan, sir.
Thank you, Rajlakshmi. Thank you, Manu. It's a pleasure being back with all of you. And welcome to all those who are, participating in today's program from various places. I understand all of you are practicing oncologists. So it is a great pleasure to be here. And the last two sessions I understand has been on pain, and communication is a pain in a way, because it takes away a lot of our time, energy, and effort, and our patients will have, and their families will have so many communication related issues, and therefore I hope you will get some benefit out of today's session. Please understand that the reason we learn communication skills is for our own selfish interest, because good communication skills is supposed to save you time, energy, effort. It should get you better clinical outcome, and it should keep us safe. So 5 very important, very selfish reasons why we should be learning communication skills. And we have a lot of things to cover. So therefore, without much ado, I will straight away start sharing my PPT. Manu, tell me if you can hear, if you can see and hear me, okay? If you can see the PPT and hear me, okay?
Yes, sir. Yes, I can see your PPT and as well as I can hear you, sir.
All right. So today we are going to cover some general parts of communication skills, which includes active listening. Active listening being further subdivided into some body language and some verbal spoken words. Not very extensively because of shortage of time. We'll then touch upon communicating bad news, and thereafter we will go on to how to manage collusion, because without managing collusion it is difficult, or rather not appropriate, to communicate bad news. So once we have done with collusion management, then we'll go back to communicating bad news, this time on how to do it. And we'll also touch upon anger management. I understand that we all are practicing doctors, and we all have been communicating with our patients and families. And often the question is, what's the point of skills like this? We are not here to, we are here to diagnose and treat them, not to make them feel good. The point is, diagnosing and treating them is great. It is part of treatment. But many times the patient and family says the treatment was good, but the care was not. And the care part comes where they have to feel that the doctor, nurses, and the whole ecosystem was caring enough. They have to feel our empathy and how to go about it. That is what communication skills is all about. Improving patient satisfaction. Now, of this active listening skills, very important aspect is the body language. Many a times we are not aware of how our body is reacting. Where is our eye contact? What is the expression on our face? What's the tone of our face? A lot of things we are not really aware when we are having communication with our patient and family. And therefore, we may be sending mixed messages. We may be saying something, but our body language may be saying something else. And this can lead to confusion and dissatisfaction. For example, look at this picture. Here you have uh, a lady a lady healthcare professional who is standing by the bedside of the patient, and the eye contact is being made. However, this patient has to turn the head at an acute angle to make this eye contact. Whereas, if when we visit our patients in IP, if the starting point, if we were to position ourselves near to the foot end of the patient and do the casual inquiry things, how are you today, what are the problems, all of those things, if we position ourselves here, and then the patient will be able to make a more comfortable eye contact, then we can move in to do the physical examination and if any procedures required. Or better still, if we can sit down by the bedside of the patient, perhaps nearer to the foot end, so that the eye contact is not only comfortable but now is at level. When we are standing and talking, we are creating a hierarchy in eye contact, whereas if we sit, we are creating equality in eye contact. And in communication skills, it is well known that when you create equality by positioning your body at the same level as your patient or the family member or whoever you're talking with, then that increases satisfaction. And this is another example of a medical professional who is bending at the knee to create eye contact at level with a child, because children are smaller in size. So many times we as adults we have a tendency to bend at the hip and look down upon them, and thereby creating fear among children. So if we just pull up a chair, sit down besides them and create eye contact at level, it increases satisfaction. So therefore, as much as possible, when patient and families come to you in your OP, offer them a chair to sit down. When you visit them in the IP, just pull up a chair and sit down. Don't You don't have to increase the time of the time you spend per patient. If it is total 5 minutes in IP per patient, and of that 5 minutes, maybe 1 minute or 2 minutes goes into physical examination and or maybe writing some notes or giving instruction, what the 2 minutes that you would be spending uh, conversing with the patient and family, if you can do that sitting down, that enhances satisfaction for the patient and family. And satisfaction means they will not only like you more, they will also start trusting you more. Some of the verbal do's and don'ts include, when people say something, don't assume based on what they say, because they may have a meaning behind what they say. For example, if somebody says, I am so worried, and you as a doctor, you may assume that they're worried about their disease. It may or may not be true. Maybe they're worried about the finances. Maybe they're worried about who are we going to get to come and stay with me in the hospital, because everybody is busy or children are abroad. They may have to ask a relative. So there may be other worries apart from their pathology. So when somebody says, I'm worried, instead of assuming, if you just ask, what are you worried about? Or why did you say that? Then they will tell you. And therefore, you will get the right information. And information is always power, but it is not power if it is a wrong information. And we are likely to have wrong information if you assume. Therefore, always ask, never assume. Then, uh, being oncologist, it may not be possible to always have uh, good news for patients and their families. But whatever be the situation, never send them away without hope. We always have to give them hope. The only problem is that we have to give realistic hope, never give false hopes. For example, if you have a patient who is has an incurable, progressive, advanced condition, and if you tell them, you go home, eat well, get better, and come back, and then we will see, that further treatment options are not feasible, but out of the kindness of your heart, you don't have the will to say nothing more from my side. But instead of that, if you say you go home, eat well, and get better, and then come back, and then we will think about it, think about further treatment, then the whole focus of the patient and family when they go back home is to eat and get better. And we all know that is not going to happen with an incurable, progressive, advanced medical condition. We know it's not going to happen. Only thing that actually happens is the patient is force feeding happens, and the patient suffers because of that. So instead of that, if we can say that the disease is progressive and does not seem to be working, it does not seem to be, the treatment does not seem to be working. However, I'll make sure that you do not suffer, and you can come back to me as long as you require. So we'll make sure that you don't suffer from it. And this is something that I do on a regular basis. Patients are sent to me from various departments with incurable, progressive, advanced medical condition, especially from oncology. And this is the conversation I have with patient and family. And you know what? They say, Doctor, adu keta madi. And that is all that I wanted to know. And therefore, it is important to give hope, but it's also important to give realistic hope, something that you can deliver. Coming to breaking bad news, essentially it is about telling the truth. And telling truth was never something anybody fancied, because it is very painful to tell the truth. So nobody wants to tell the truth. Most time we don't want to hear the truth. And therefore Plato said, no one is more hated than he who speaks the truth. Therefore, breaking bad news is nothing but telling the truth. Most of the many countries practice, the doctors practice non-disclosure model. That means you tell the family, you do not tell the patient. And many times if the patient comes with the family into the doctor's consultation room, the doctor usually would ask the patient to leave the room. And the patient is standing outside, knowing fully well that they are talking about me, but they will not talk to me. And it's a very, very uncomfortable situation. I don't know how many of you, God forbid, if you are in that situation, how many of you would be happy to be asked to leave the room while another doctor is talking to your family, but the doctor refuses to speak to you. Therefore, this can lead to a lot of dissatisfaction and lead to a conflict of the patient's right to know. The patient may want to know for various reasons. They may have things to do, they may have plans, or they just want to know. So when you practice non-disclosure model, it gets into conflict with the patient's right to know. There are some countries where you have to convey the truth to the patient, and you can convey it to the family only with the permission of the patient. So therefore, that is called a full disclosure model. That is, you convey to the patient. However, what if the patient does not want to know? There could be a couple of patients like that, or who may not be mentally prepared right now. So what happens to that? That also goes into conflict with the patient's right not to know. Therefore, the full disclosure model or non-disclosure model both has a problem, because it gets into conflict with what the patient wants. Therefore, we need to think of another model, and therefore we call it individualized disclosure model. Basically, what it means is that we doctors need to find out whether the patient sitting in front of us wants to know or not, and and then we need to figure that out. And the second thing is we also need to figure out whether the patient who wants to know, how much the person wants to know, whether the person wants to know everything or a little bit of it or some moderate quantity. So we have to facilitate information in a way that it is neither less nor more, because less would be unsatisfactory, more may cause psychological trauma. Therefore, just the right quantity that the patient wants. So this is the basic premise of the individualized disclosure model. Now, coming to how, or rather, coming to why it is important to communicate bad news. Primarily, I am giving you 3 points for to think about. If I knew that I had limited time, then I would want, after the initial shock, after the initial bargaining, and after the initial crying and the sadness, once finally I come to terms with it, and you need to give me some time for it. And once, with some time, with a few days behind me, I come to terms with the reality of my life, that I have an incurable, progressive, and advanced, let's say, malignancy. Then I will consider what are the things that I need to do to finish before I die, and what are the things that I need to do before I become incapacitated, that is even before I die. What are the things that I need to do before my mind stops working, that is even, along with my physical debility, or even before I die. So there are a lot of things that we all keep postponing, and it could be our bucket list. There are things that we want to do. It could be about sorting out financial issues. It could be about planning for our children's education or marriage. It could be any number of things. It could be mending a relationship which has broken down, to ask forgiveness, to give forgiveness. So a lot of things are there to, if we just start seriously thinking, if our life were to finish in a week's time, then what is really important to us, and what do we need to finish. So we get a chance to finish the things that we need to finish in our life. And that is something which is very important. Oftentimes our patient don't get a chance for it because we perhaps may not have made an effort to convey the truth to the patient. Another issue is hospital hopping and doctor shopping. If I have this incurable, progressive, advanced medical condition, but nobody told me, and my family knows, but I don't know, then what happens? My expectation, from my point of view, is normal, but from your point of view, it is unrealistic. The only difference is you know the reality, I don't know the reality. Therefore, what is normal to me becomes unrealistic to you and for everybody who understands my reality, except me. But for me, my expectations are perfectly normal, perfectly legitimate. And if you are not able to meet my expectation as a doctor, as a hospital, as a family member, I will be dissatisfied. And if I'm dissatisfied, I will stop trusting your treatment. And then I'll ask, or rather demand, with my family member that you take me to some better place. And even though my family member may know the truth, they are helpless. They can't say, no, no, you continue at the same place. So they will be forced to take me to another place. And what happens there? There, my hopes rises initially, then it crashes ultimately. Then I demand to be taken to another place. Then the same thing happens. Then I demand to be taken to an Ayurveda center or a Homeo center or a Unani center or a Baba's ashram or someplace, because I am desperately looking for a cure that does not exist. But nobody told me that. And meanwhile, while my expectation rises and my heart is broken again and again and again, my body is becoming weaker, I could have stayed at home and take all those medicines to keep me comfortable. and I could have finished a lot of things that I needed to finish. But that doesn't happen because I'm looking for a cure, because I need to get back to my normal life. Now, what about my family? They understand that this is a futile enterprise, but they are forced to do it. And when you stay away from home, when you're going from place to place, it costs a lot of money. And financial toxicity is a very real entity. A lot of bankruptcy and poverty happens because of financial toxicity of associated with modern medicine. And therefore, at least some of that financial toxicity could have been controlled if only truth was shared. The third point is barriers in relationship. Many times, because the patient has not been told the truth, the family members are are not able to express their their emotions in front of the patient. They pretend as if everything is fine and normal, but once when they feel overwhelmed, they may run to another room and cry there and wash their face and come back and stand in front of the patient with a mask and behave as if everything is normal. It is like playing a drama. And the tragedy is there is so little time. This is not the time to play drama. This is the time to hug and cry and say I how much I love you. But that doesn't happen. And whether the patient belongs to a hut or the patient belongs to a palace, the family members will often come to the doctor's consultation room on proxy visits and cry their heart out in front of us. Now, that is tears wasted, because the real strengthening of relationship would have happened if there was honesty and transparency between the patient and family. And who should have facilitated that? I think somewhere we also need to raise our hands and take some responsibility for that. Therefore, these 3 points: closure of life's business, hospital hopping and doctor shopping, and barriers in relationship, these are an outcome of not communicating the truth. And because we, being in the medical field, we are not prescription vending machines, we are doctors, and that means we have the role of a friend, guide, and a philosopher to our patient and families. And therefore, our job is much more than diagnosing disease, treating disease, palliating their symptoms, and writing prescription and doing procedures. And that is why communicating bad news is important. Now, many a times, the family members themselves come to us and says, "Doctor, please don't tell it to the patient." And the reason why they do is because they are trying to protect their loved ones. And therefore, they want to enter into a conspiracy of silence. Because the whole idea is, doctor, you share the information with us, but do not share this with the patient. So that is what the conspiracy of silence is. They want us to enter into this conspiracy where we maintain silence of the truth with the patient, because they are anyway doing that. The family members would have entered into a conspiracy of silence with the neighbors, with the patient's friends, all their relatives, with the whole world, and to keep the information out of the patient. Now, the first thing that we need to understand is, just like the patient is suffering, the family is also suffering. Because look at their tragedy. They are so scared of bringing the patient to us. But at the same time, they need our services also. They are scared that we may perhaps inadvertently tell the truth or hint at the truth to the patient. And they believe this will damage the patient. Each one of us have our own sets of beliefs. It could be religious beliefs, it could be political beliefs, it could be philosophical beliefs, any beliefs. But for us, our belief is real. For another person, it may appear to be stupidity, but for us, our belief is real. Similarly, for the patient, for the family member, their belief is real for them. So they are scared. They are suffering. Therefore, first we need to palliate their suffering, the family member suffering. And when somebody is coming to us trying to collude, please understand they are scared, they're anxious, they are fearful. And the first step and the most important step of collusion management is to agree to collude. Because when you say, okay, no problem, immediately the family members' fear, anxiety, and all those suffering that gets palliated. That doesn't mean they have started trusting you, but at least they have some reassurance that this doctor will not tell the patient. Now, the second step of collusion management is to earn their trust. And to earn their trust, active listening skills, you have to listen to them, hear them out. Also, another important tool in your hand is learning symptomatology, how to treat pain, how to treat breathlessness, how to treat whatever the physical suffering that the patient has. When you palliate their distressing symptom and it brings a smile on the patient's face, the family members will trust you. Therefore, it's a very, very powerful tool, the symptomatology that you're learning as part of this program. That will also help. So, good active listening skills and good symptom control will earn the trust of the family. And when the family starts trusting you, it could be the first meeting or the second meeting or the third meeting, whatever it is. Once they start trusting you, then they will start listening to you, not before. And once they start listening to you, then you can communicate to them the importance of why it is important to communicate bad news. The patient will get a chance to finish whatever they need to finish. It will prevent hospital hopping, doctor shopping. It will also strengthen the relationship between the patient and the family. But please understand there will be failures, especially if you are new to this. This is a skill that comes with continued practice, continued polishing up of the skill, and there will be plenty of failures. And there is no shame in failure. The only shame is in not trying. Because as you try, you get better and better, your conversion rates will improve. However, there is no such thing as 100% conversion. Everybody constantly will face failures. That means the family will, despite your best efforts, the family will not agree for collusion. So when you feel that the family, despite your best efforts, the family is not agreeable to it, don't make this your agenda that you somehow have to convince the family, because then if they feel that you have an agenda behind it, then they will lose the trust that you have so painfully created, and this will lead to friction in relationship, and that is absolutely something that we do not want. So if the family does not give you the green signal, then don't push it. Now, coming to how to communicate bad news, this is assuming the family has agreed. Because in our country, in our ecosystem, it is not the patient which comes to us, it is the family members. It's the family which brings the patient to us. Therefore, in our ecosystem, patient autonomy is not as sacred as it is in some other ecosystem. In fact, in our ecosystem, patient autonomy is subservient to the family's right over the patient. So, family's right over the patient is always above the patient's individual autonomy. Therefore, to communicate bad news to the patient, it is important to have the family agreeing to it. So that is where the collusion management works. It is it is rare where a family member will come and ask us, request us to help them communicate the truth to the patient. That happens. It has happened to me a couple of times, but it is not very often. Most of the time, we are dealing with collusion, and once we manage collusion, the family agrees, and oftentimes the family asks me, can you tell this to the patient, doctor, എനിക്ക് പറയാൻ വയ്യ. That means I can't tell this to my loved one. Will you kindly help me? So I tell them, okay, fine, I will help them out with it. But I also tell them that while you have given me the green signal for this, however, if the patient, their loved one, does not want to know about it, then I will not force the information. So that is the caveat I always give to the family members. Now, coming to the communicating bad news all over the world, the usual protocol is the spikes protocol, and that is the acronym which means setting up the interview. I usually have in my OP drinking water, paper cups, and paper tissue, and all, and a lot of extra chairs which I can stack up in case there are more people who comes in. So basically, I create kind of an environment which is more comfortable for this. Usually, if it is an elective procedure, I prefer evening time when the most of the rush is gone and it is quieter. If I'm doing it in the IP, well, I take whatever time that permits. Basically, you have to understand that you will need time for this. It is like an elective procedure. It's like an elective surgery, and you may have some idea of how much time it might take, but be prepared for sometimes the session going longer. Second point is perception. Basically, find out what does the patient know. Now, this is something that we need to do while we are doing history taking. While we are finding out what the patient's story is, also important to find out what the patient understands about what is going on, the patient's insight. Then we have to get the patient's invitation, and once the patient invites us for this conversation, then we can share the information, which is knowledge. And once you do it, emotions are bound to happen. We have to deal with it. And once the emotions are dealt with it, then we can talk about what can be done, what can't be done, how to go about it, etc., etc. And then we finish. So this is basically the SOP. So here is a small story of Mr. Bharat, who is a 60-year-old gentleman who has been having discomfort of the abdomen and weight loss of about 2 months duration. So initially, he went to the local GP and tried some medications, didn't work out. Then, uh, then an X-ray was done and saw something, and referred to the gastro doctor at the city hospital. So their evaluation was done. CT abdomen showed a mass lesion stomach, and OGD biopsy showed CS stomach. An exploratory lab was done, and which showed multiple peritoneal metastases, and surgery was abandoned. The abdomen was closed, and now this is, I mean, as oncologist, you may now be thinking about various pathologies, but please don't go there. This is a session on communication. So simply put, now this disease is deemed to be incurable, progressive, advanced, and the patient has been referred to you for symptomatic and supportive care. Even in this day and age, nobody writes palliative care because there is still a lot of stigma attached to referring for palliative care. So the referral uh, verbally or on written is usually by the word symptomatic care or supportive care. So the patient is sitting in front of you. Now what? So step one, we have to find out if the patient says, Doctor, what is my problem? Then you don't have to explore because the patient is already exploring. If you have a silent patient who is not asking questions, then you can explore. Mr. Bharat, basically, you said that all the surgery, etc., has been done. So you have come here. Do you have any questions? Do you want to know something, anything more than what you have already told me? So Mr. Bharat says, yes, I want to know. So now at this point of time, please don't start telling the truth because we still don't know whether this person would want to know if it is something serious. Therefore, we give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? In Malayalam, maybe I'll say, Mr. Bharat, കാര്യങ്ങൾ സീരിയസ് ആണെങ്കിലും അറിയണം എന്നുണ്ടോ? In Hindi, I might say, Mr. Bharat, अगर बात कुछ serious हुई तो क्या फिर भी आप जानना चाहेंगे? So basically, the warning shot is the most important part of the process of communicating bad news, because this is the point where the meeting, till now it was a normal conversation, suddenly with a warning shot the atmosphere becomes serious, and now we are giving a choice to the patient that if it is something serious, would you still want to know? And if the reaction is something like this, no eye contact, then that means the patient does not want to know. Or the patient may briefly make an eye contact and may change the story. Doctor, just give me some medicines and I'll come back after 2 weeks. That means the patient does not want to know. Or the patient says something like, tell it to my children, or simply, no, I don't want to know. Mostly focus on the body language. And in situation like this, do not proceed. You give a warning shot, you say something like this, do not proceed. However, if Mr. Bharat were to look into your eyes and say yes, then no confusion. So the first part of individualized disclosure model, we have to figure out whether the person sitting in front of you wants to know or does not want to know. So that criteria is fulfilled. For this, the trigger is the warning shot. You give a warning shot, and then you are able to figure out whether the person sitting in front of you does not want to know or wants to know. Proceed only with those who wants to know. Once you have figured out what type of patient is sitting in front of you, then you can proceed with the patient who wants to know. And then how do you proceed? You tell a story. You tell a story of the patient to the patient from the beginning. And while you're telling the story, you fill in the blanks. The filling in the blanks comes in because while you were taking history, you found out what is the insight of the patient. For example, Mr. Bharat, tell me what your problem is from the beginning. Sir, I was having abdominal pain and discomfort, and my shirt, everything was getting very loose. I was losing weight. How long has this been? For about 2 months. Then what happened? Initially, I went to my local doctor and he gave me some gas medicines and all, which I took for 1 week. There was no relief. Then, then I went back to him and I told him that I am not having any relief. So then he asked me to get an X-ray. Okay. Then what? So then he gave me a letter to go to see the gastro doctor in the city hospital. But did he tell you what was there in the X-ray? No, he just he asked me to get the X-ray. Once the X-ray was done, he looked at it. Then he said, I'm giving you a letter, you go and meet the gastro doctor. Okay, then what happened? So I went to the city hospital and I met the gastro doctor. There a lot of doctors came and saw me, and then a lot of tests were done. And then they said that a lot of money was spent on this CT scan of my tummy, and then they also did a tube test. And after all of this test, they said that I need to undergo a surgery. So hold on. So you said that you did a CT scan of your tummy. So what was the result? I don't know what the result. They said something in English and all. I didn't understand. They said there was something. So okay, what was the tube test all about? Why did they put a tube into you? And they said it is part of because they saw something in the scan. They want to find out what it was, and that is why they did the tube test. And what was the result of the tube test? They said that I don't know what, but they said that operation is required. I said, okay. Then what happened? I didn't have any money at that time, so I went back to my village and then I sold my cow. And then I arranged some more money, and finally I had enough. So I contacted them. I got a date, and then I got admitted for surgery. And then what happened? Well, after surgery, they said that I'm giving you a letter you go to this place and meet this doctor. That is why I'm here. But what did they tell you about the surgery? What happened in the surgery? They said that surgery is over. And what did they find in the surgery? That I don't know. They said, but they said the rest of the treatment will happen here. So the letter is, so they gave me this letter. Okay. Did they tell you why they're referring over here? They said the rest of the treatment will be here. So this, the way if we dig more information, we'll understand that there are a lot of blank spots in the patient's insight, the patient's perception. There may be some right information, there may be some wrong information, but there will be a lot of blank spots. And the storytelling involves filling in the blanks. And as you fill in the blanks, you escalate the information. And while you're telling the story, you focus on the patient's body language. If there is eye contact, you continue the story. If the eye contact stops, you pause the story and wait for the patient to again regain eye contact. Because when you have given some totally new information, the patient may break eye contact because the patient is trying to digest the new information. If the eye contact is not there for a prolonged time and you don't know what to do, and you're also getting uncomfortable and you don't know how to proceed further, then you can break that prolonged uh, lack of lack of eye contact and the prolonged pause by asking a question whether you want me to continue further or do you want to know more, something like that. And if the person again makes eye contact, you can continue the story. If the patient continues not to make eye contact, that means the patient had enough. And that is the point. You stop the story. You don't have to finish the story. You stop the story where the patient's body language conveys that the patient had enough. That way, you are going to be able to share the right quantity of information, not less, not more, the optimum dose. And that is how we will tell the truth. So, a small role play, telling a story honestly and with empathy. Mr. Bharat. So basically, this is after telling, giving a warning shot to Mr. Bharat, and Mr. Bharat's response has been like this: yes, I want to know. And so the role play starts. Mr. Bharat, you have been suffering from gas since about 2 months, right? That is what you told me. And you went to your local doctor and he gave you some what you call gas medicines, and you took for about 1 week, if I'm not mistaken. And you said there was no relief. So you went back to get the X-ray done, right? So the X-ray showed something like a shadow. And to know more about the shadow, he referred you to the city hospital. Oh, I didn't know that. Well, in the city hospital, uh, you said that a lot of doctors came and so, and the scan was done. The scan showed something like a tumor. And to know what this tumor was, they did the tube test. It's called endoscopy. And the tube test was done to see if your tumor was anything serious or something like a cancer or something like that. Now, if you would notice, initially the filling in the blank is something like a shadow. In the next sentence, it is no longer something like a shadow. It escalates to becoming a shadow. It is no longer something like a shadow. And then shadow escalates into something like a tumor. Then something like a tumor escalates into a tumor. And the tumor then escalates into something like a cancer. So in Hindi, I would say something like एक्सरे में परछाई जैसा कुछ दिखा और ये परछाई क्या है जानने के लिए आपको सिटी हॉस्पिटल भेजा गया था। वहां पे स्कैन लिया गया, उसमें गांठ जैसा कुछ दिखा। ये गांठ क्या है जानने के लिए आपका फर्दर आपका ट्यूब टेस्ट करवाया गया। और ट्यूब टेस्ट करके ट्यूब टेस्ट देखने का मतलब पर्पस ये था कि जानने के लिए कि ये कोई कैंसर जैसी कोई बीमारी तो नहीं है, कर्क रोग जैसी कोई बीमारी तो नहीं है, तो समथिंग लाइक दैट. അപ്പോ എക്സ്റേയിൽ മുഴ പോലെ എന്തോ കണ്ടു. ഈ മുഴ എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് സിറ്റി ഹോസ്പിറ്റലിൽ വിട്ടത്. അപ്പൊ അവിടെ സോറി, എക്സ്റേയിൽ നിഴൽ പോലെ എന്തോ കണ്ടു. നിഴൽ എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് സിറ്റി ഹോസ്പിറ്റലിൽ വിട്ടത്. അവിടെ സ്കാനിൽ മുഴ പോലെ എന്തോ കണ്ടു. ആ മുഴ എന്താണെന്ന് അറിയാൻ വേണ്ടിയാണ് ട്യൂബ് ടെസ്റ്റ് ചെയ്തത്. അപ്പൊ അത് ട്യൂബ് ടെസ്റ്റ് ചെയ്യുന്നതിന്റെ പർപ്പസ് ഇത് ഈ മുഴ ക്യാൻസർ പോലത്തെ എന്തെങ്കിലും കുഴപ്പം ഉള്ള മുഴയാണോ എന്നറിയാൻ വേണ്ടിയാണ്. So, do you mean to say that I have cancer? I'm sorry. Yes. Mr. Bharat, do you want to know more? So they had operated and removed my cancer, didn't they, doctor? They did operate, but I'm sorry, when they opened up your tummy, they found that the cancer had spread all over. They could not remove it. They lied to me. So now the emotions have started coming. Now, when people start ventilating emotion, the most important thing that you have to do is don't do anything. Don't say anything, don't do anything, just be with the patient. Because a human being needs another human being to ventilate their emotion. So, for the patient, you, the doctor, you are the human being presently available. And you are the one you are having this conversation. So, suddenly, when the patient starts crying, you cannot be replaced by a social worker or a clinical psychologist or a nurse who may be around. It is you who have to be there. You can touch for a moment if you're comfortable about it, the patient. Don't pat, just a touch, and then take your hands off. Don't say anything, don't do anything. This is like in surgery when there is an unexpected bleeder that the surgeon can't cauterize or ligate. Then what do? You pick up a pad and put pressure on it. Everything stops. You just put pressure and wait till the bleeding stops. The same situation. The analog is similar. So right now it is time to ventilate emotion. Let the emotions be ventilated. This time, even though it may be just 1 or 2 minutes, we as doctors, we are not used to not doing something. And therefore it will seem like 1 or 2 years, that 1 or 2 minutes. It is going to be very, very uncomfortable, but that is the skill of communication that we have to learn. Don't do something, don't say something. For God's sake, don't check Facebook and WhatsApp while this patient is ventilating. Don't look at your watch. Don't look at the case sheet. Don't look anywhere. Just focus 100% on onto the patient. Don't stare at the patient, or you can be just there sitting with the patient while the patient ventilates. This is again a very, very important point in communicating bad news. Once they have gained some control of themselves, then they may ask questions. Doctor, how much time do I have, doctor? And the doctor is nothing is possible, doctor. I'm so worried, doctor. I'm so scared, doctor. All these kinds of questions will come up. Now, again, our instinct would be to reassure them, don't worry, we are here. We all are here to help you. God will help you. We will say so many cliche things. But please remember, whenever people are saying something with a lot of emotion, don't assume. Ask, why did you say that? Ask, how much time do I have, doctor? Why did you say that, Mr. Bharat? My daughter's marriage is fixed after 6 months. Should I prepone it? So this Mr. Bharat asked this question, how much time do I have, doctor? Because this Mr. Bharat, had some plans. Another Mr. Bharat How much time do I have, doctor? Oh, Mr. Bharat, why did you say that? Why did God do this to me? So, same question, but totally different reason for saying that or for asking that. So, if you have 100 people who ask this question, they may have 100 different reasons for saying that. That is why we are individuals. Nothing about us is similar. Lot our social realities, our financial realities, our belief system, what is important to us, etc., etc. It's all very unique to us. That is why we are individuals. And when we say something, there's a very individualistic reason for it. So therefore, do not assume. Ask, and then you will get to know why people said. And if you have a solution for like this, if somebody's said this, I may say, I don't expect anything much to happen, but if it's possible to prepone it, there is no harm. You can still enjoy your daughter's marriage and you are still having reasonable health physically and mentally. So there is absolutely no harm. If possible, please prepone it. And for here, I may just spend some more time allowing this person to ventilate further. However, after all the emotional ventilation has been done, then we can get into this area of what can be done, what cannot be done, and ultimately finishing off with realistic hope. And that is how we wind up our conversation. Now, this whole conversation, while we're taking this class, may seem like a long one. It usually wouldn't stretch beyond 15 to 20 minutes. And with all the ingredients that we have put in on active listening skill, body language, the verbal do's and don'ts, and how we go about telling it, it doesn't take a lot of time. But sometimes, unfortunately, some sessions may go longer, but that is would be an individual patient to patient variation. By and large, on an average, it doesn't take a lot of time. Another issue that we all, irrespective of a profession we are working uh, in specialty of working in the medical profession, we have to deal with anger. Now, when I talk about anger, I'm talking about the clinical management of anger, not dealing with law and order situation, because we are trained to be doctors, not policemen. Even if you are given a lathi, I doubt if any of you would be able to break somebody's head or at least somebody's leg using their lathi. So just because we are not trained, but give it to a policeman, the policeman can easily break your head and break your legs and your liver and everything with that lathi. That comes with training, and we are just not trained for that. So if you are dealing with a mob, 50 people very angry trying to kill you, run away from that place as soon as your legs can carry you. Or if you're dealing with somebody under the influence of alcohol or other substances, you just can't reason with somebody like that. Then it's better to move away from that place, stay safe. But oftentimes you will have people getting angry outside the emergency department, casualty, or ICU, or outside your OP. And that can easily get out of control and become a law and order problem. And therefore, it is good to control it there itself. So, what is anger? It's an emotion, it's a negative emotion. But unlike crime, which is again a negative emotion, sadness, which is a negative emotion, anger consumes a lot of energy. It needs a lot of energy to sustain anger. There are two forms of energy. One form is confrontation, any kind of confrontation, arguing with a person or making excuses or anything. Even if somebody is very, very angry, if you smile at that person or if you apologize to that person, that all, everything and everything can become confrontation. Another category of fuel that can sustain anger is ignoring the angry person. No confrontation, but ignoring. If you maybe you're ignoring because you are scared, because that angry person is making you very uncomfortable. You don't want to make eye contact. You turn your back towards this angry person. All of this can also make the person very angry. So damned if you do, damned if you don't. That is the situation. So how do you deal with it? It is just like doing ascitic tapping. You if you punch the uh, highly uh, what do you call, if you punch the abdomen, that does not take care of the ascites. If you ignore the abdomen, that does not take care of the ascites. You have to put in a needle and allow the fluid to drain in a controlled manner. So that procedure in anger management is your body and your body language. So what do? First, whenever you see somebody who's angry, then you would have noticed that angry person is not relaxing and sitting down and getting angry, because there will be so much of adrenaline that angry person's body will not allow that person to sit down. So an angry person would usually be pacing around, walking around, or would be standing, will not be sitting. So to make your eye contact at level with the angry person, you also stand up. Many of these WhatsApp videos where you see doctors getting beaten up, if you notice carefully, the initial part before the doctor beating gets the beating, the doctor would be usually sitting behind a table and arguing with people. And this escalates, the people get more and more angry, and this escalates, and finally the people jump over the doctor and starts beating him or her. So first, always stand up, because when you stand and make eye contact, you are showing equality. That's a positive body language. So whenever you're creating positivity, you counter negativity. Then when you stand with a slight kyphosis, a slight bent forward posture, not exaggerated, just a slight. That shows respect. Respect is again another positive body language, and you counter anger negativity with positive body language. And also keep your hands where the angry person can see, because when somebody is angry, that person is also scared. The fight and flight response is there. So anybody who's angry is also a scared person, and a scared person or a scared animal can hit out. So universally, showing of hand in the form of namaste or blessings or salute or high five, whatever form it is, showing of hands is a psychological messaging that I do not intend to harm you. I do not have a hidden weapon in my hand. I come in peace. So again, it is a non-threat. You are showing the angry person, I do not intend to harm you. I am not a threat to you. Another positive body language to counter the negativity of anger. So this is the three important part of your body. Then the face. Make eye contact, because when you make eye contact with an angry person, you are showing that I am confident, I am not scared of you. Again, a positive confidence is a very positive body language, and it also counters the negativity associated with anger. And usually I would recommend smiling, but with an anger situation, I would recommend never smile. Keep your face serious, because you are conveying I'm listening to you seriously. And encourage the angry person to ventilate the anger by nodding your head, not in an exaggerated manner, just like as if you're as if you are participating in a casual conversation. The only difference is you are not uttering a word from your mouth, only your body is conveying the messages, not a single word from your mouth, not a sound, just your body language. Now, this will work as the needle, which will allow the anger of the patient or the angry person to be ventilated in a safe manner. So, what are the situation? Here is an angry person, and you can detect that this language, this person is talking about your genetic material. This person's volume is very, very loud, and the facial expression is obviously very angry. But when you employ all of these tactics, gradually the flaming anger comes down to simmering anger. Now the cuss words are less, the volume is moderate, the facial expressions is a bit more human like. And when you have the patient who is now, the simmering anger is there, Now is a good time to invite this person to sit and talk. It is important for two reasons. Because when this person was getting angry, this event was happening in a public space, outside the casualty, outside the ICU, in the OP, in the waiting area. And everybody, any patient and family who comes to the hospital, they come not because they want to come to the hospital, they don't want to come to meet you. They come because they are sick, they are suffering, and therefore they are forced. Every patient and family is forced to come to us, and therefore the starting point itself is negative. So all the patient and family members, or anybody who is in that area, everybody is stressed, whether they are waiting outside the casualty or waiting outside the ICU or in the OP area, everybody is stressed. So when they see one person who is very angry, this anger is very infectious. And from one situation of clinical anger, it can easily spread to a lot of people, and then it becomes a law and order problem. So therefore, from this severe anger, you bring it down to simmering anger, and then you invite this person to let us sit and have a conversation. And with this, you are taking this person, you're removing this person from the public space into a private space. The moment this person is removed from the public space, the activities in the public space will start like before. People will start walking around and everything will get back to normal. Therefore, that is one point. The second point is that person still has anger issues. Therefore, now we can sit down and then continue this conversation. Basically, you are saying, ye dil mange more. You want to know more about this. So you say, sir, I want to know more about this. Can we sit down somewhere and talk? And then you guide this person to a inner room somewhere. You find some place, because this is an emergency situation. You find some place. You have to clear out somebody and get a closed enclosed space where you can sit and talk to this person. While sitting, you also may continue making eye contact. You keep the face serious. You nod your head, and when you're sitting, you sit with a slight kyphosis, that is bending a little forward, because this conveys, I'm here to listen to you. And then the patient or the family member who was getting continues to ventilate their anger. And in my couple of experiences, they end up crying, or they end up profusely asking for apology for creating a nuisance. So that is how we should finish this at a good point. Remember, our job is not to find out the problem. Our job is to make sure that no damage is caused because of that anger. The anger situation, the ventilation of anger is the only thing that we should be focusing on. And at the end, if we find a problem from based on what the angry person told, and if some solution is possible, by all means guide the person to a solution. But many a times you may not have a solution. And also, if there is a solution, do provide a solution. If the situation merited an apology, do give a sincere apology, but never apologize for the sake of apology. Never give a false apology. Never give an apology for the sake of apology, because that itself will give a bad taste in the mouth of the person who just interacted with us. Offer apology only if it is merited. For example, thank you for bringing this to our notice. We are very sorry you had to experience this. Another option is without an apology. Thank you for bringing this to our notice. This is what we are going to do. I'm going to inform the operations manager that something like this was there, and make sure that this doesn't happen to anybody else. So finishing off with take-home points, sitting and talking gives more satisfaction than standing and talking. Assuming comes very easy to us. Do not assume, ask. When people say something, ask, why did they say that? When it comes to collusion, focus on the family's distress and how to palliate the family's distress. That is the first step and the most important step to managing collusion. Second, get their trust. When it comes to sharing information, communicating bad news, the most important step is giving a warning shot. Remember, you are only a facilitator of information. It is not your agenda to convey full information or whatever information that you think is relevant. No, we have 100% information. The patient decides whether they want to know it or not. They decide how much they want to know. We only facilitate that. When it comes to ventilation of emotion, whether it is tears or anger, ventilation of emotion is a therapy, it's a skill. Unfortunately, we are not going to be able to monetize it. Whereas clinical psychologists, by the nature of the profession, they can monetize it. We have to do it free of cost. And always, in the end, give realistic hope, never false hope. When it comes to dealing with an angry person, don't be stupid. You are smarter than that angry person. Don't take any of those uh, crap that is coming out of the mouth personally. Our job is to ventilate that anger in a non-confrontational manner. Non-confrontational active ventilation of anger is an easy skill to master. It keeps us safe and keeps the environment safe. So I'll stop here and stop sharing. That was a long monologue. I'll now uh, shut up and listen.
Thank you so much, sir, for the excellent class. That was more than just a class. It was really like it was an eye opener. And I think this is one of the best communication class I have heard also. Thank you so much, sir. Now now it's open for discussion and questions. Those who want to ask can unmute and ask or put the questions in the chat box.
Not just questions. If anybody is interested to share their experiences, most welcome. It will be a learning experience for all of us to listen to individual experiences and how you dealt with it.
So was there any situation, a situation worth mentioning, which you had in your practice? Maybe one experience? So Biju sir, can you listen?
The question was with me. Question was to me.
Yeah, yes, sir, yes, sir. Was there any really interesting situation where you had you're finding it difficult, like regarding the breaking bad news or any collusion, especially collusion, sir? Because that was one thing which we face very often, the family and the relatives.
Well, collusion is something that we deal with on a daily basis, actually. And
Yes,
my only no experiences, but the point is that the failures is the hallmark of collusion management. There'll be plenty of failures, but the point is it has happened many a times where the patient sitting in front of me is asking doctor, what is my problem? And the family member standing behind the patient is saying,
exactly, sir. Exactly, sir.
so they are not verbalizing it from, but body language they are conveying,
Yes, sir. Yes, sir. Correct.
So then, in that kind of situation, you have to buy time uh, because you can't say the truth, and you should not say a lie. But thankfully, there's a lot of gray between white and black, and we play within that gray. For example, I will tell the patient that I don't have enough information right now to make a comment on your question. Now, is that the truth? Am I lying to the patient? Well, I have the medical information, but that information alone is not enough. I don't know whether the family member will allow me to communicate the truth to the patient. Now, that information is very important. So, yes, I am truthfully sharing, I am being truthful to the patient when I say I don't have all the information. I may have some information. That some information is the medical information. I don't have the other part of information, whether the family member will allow me to tell communicate the truth to the patient. And in that sense, I did not lie to the patient. Basically, it is playing in the gray area. So while you buy time, you make sure you are keeping the patient physically comfortable. You also cater to the patient's anxiety, depression, anger, frustration, all of that, either with counseling or with pharmacological or a combination of both. Apart from the physical discomfort, along with it, you also work with the family. I'm purposefully not using the word working on the family because it is not a procedure I'm doing on the family. I work with the family. For example, I'll tell the family, you see, now he's physically, his pain is under control, but he is saying, he's keeping asking these questions. And if he feels that, the pain is okay, but now why I'm not getting better, why I'm not, becoming normal, then I wonder what will we do. Now, please focus on this. I am talking to the family separately. I am talking to them and I'm saying, I wonder what will we do. I'm not saying what will I do. I'm not saying what will you do. I'm throwing this question up in the air, and me and the family member are now in partnership trying to solve this problem. If the patient, we say, I'm getting better, my pain is better, but I'm not getting better, I take me some other place, what will we do? So I make them partners in solving this problem. I am not offering them solution. Of course, I don't have a solution to offer. The only solution will come if the family member and me work together and resolve this problem. And I put them in some situation. What if he refuses this treatment because he's saying I'm not getting better? Then what will we do? You know, what if he wanted some things to be done, but he has never told you? And probably, if he knew the truth, he may have conveyed this or he may have demanded this. How will we know? So, these are some ways. Now, this will come over a period of time because I can't make you climb over the pebbles, the small stones and the rocks and the hills and the mountains. You have to do it yourself, and you have to try and fail, fall, and again dust yourself and again try and get better and better at it. The conversion rates improves. It never becomes 100%. The point is you learn over a period of time, or if you have some mentorship who is doing it and you're working under that person, you can imbibe some technique, some wordplay, etc., etc., etc. Apart from that, one incident I about communicating bad news. I was fairly new. I was just doing my post graduation in pain and palliative medicine, and my guru, Dr. Rajagopal, he sent me to communicate bad news to a very elderly gentleman, very distinguished elderly gentleman. And so I went there. I went and sat there and just had a conversation. And unlike classroom in real life, you don't know whether you will be able to have this conversation or not. Just go there. You don't have an agenda. You go there. If it happens, it happens. So I was just talking about this thing, and he asked a few questions, and they said, sir, do you really want to know, even if it is something serious? He said, yes, I jolly well want to know. And then, it was like Malayalam will say, "Pettu first guy." I have to. Then I sat there and then told his story from the beginning, filling in the blanks. And at the end of the session, he just sat there and listened to me, made, he listened to everything. And by the end of it, I was physically exhausted. I was emotionally exhausted. I was spiritually exhausted. I had sweats coming down. My throat was choked up. I had no voice. And I was in a situation where it seemed I would collapse anytime. And this gentleman, He got up from his bed, came over to me, he tapped me on my shoulder, and he consoled me, don't worry, everything is fine. And he consoled me and sent me off the room. So that was the first, that was the experience when I communicated bad news as individual with no, you know, not as uh, not as a spectator, but as a performer alone. It was the most horrendous experience. It was very, very tiring. It takes the whole energy out of you. And fortunately, it was a very elderly, distinguished gentleman who had seen the world and very, very wise. And he ended up consoling me, the young doctor who had done this. Malayalam will say, "Vilya sahasam kanichu." You've done this something beyond my capacity, actually. So that was one experience. But I'm sure that in front of us there are so many accomplished oncologists sitting here. I'm sure they would have more interesting stories.
Dr. Mani, you muted, sir. Can you unmute? Dr. Mani, you're still muted.
So that's a question from Dr. Gayatri. Can you hear, sir?
Sorry, is it in the chat?
Yeah, it's in the chat, sir.
Would you be kind enough to read it out? I'm
Yes,
kind
sir.
of
Sure.
struggling.
Yes, sir. The question is, in some scenarios, bystanders tend to put the blame on caregivers to hide the lapses from their side, as in delaying treatment. How do you deal with it, sir?
Oh, nice question, Dr. Gayatri. Nice question. Now, usually in my practice, uh, as a I'm not an oncologist. As a palliative care person, a major chunk of my work deals with end of life care, but that is not the only thing I do. But however, many a times whenever I'm having conversation with the family members, my usual statement would be, you have done everything humanly possible for your loved one. Why? Because each one of us, human beings, are egocentric. We see the world from our point of view. I, me, myself is the universe. So everybody is worried about what others think about them. Everybody is worried about how I appear in a situation, not just physical appearance, how I appear in a situation. So when you say statement like, you did everything possible, you worked so hard, you suffered so much, you did everything humanly possible. When I am acknowledging that they did, instead of saying we did everything possible and unfortunately things didn't work out, unfortunately treatment didn't work out, we did everything possible and unfortunately the patient is dying. Instead of saying we did everything possible, when I say you did everything possible, immediately a couple of things happen. The temperature in the room comes down. A high intense uh, tension in the room comes down. People just calm down. Because here is a doctor with a steth around the neck is saying, you people did everything humanly possible. Along with it, there might be some dynamics within the family which we are not aware of. A lot of family dynamics, politics, relationship issues. So when you say you all have done everything possible, everybody everybody gets a good ego massage, and there is less chances of saying, this person has been taking this patient to this hospital, we had told go to the other place. These kind of politics and dynamics, that also comes down, because here is a doctor with the steth around the neck saying you people did everything possible. You provided the best possible treatment. You took him to the best places, to the best doctors. You provided money, time, energy, effort, everything. So you basically make sure that you are conveying to the family that you people did everything possible. There's nothing that you could have done better, more. And remember, that is what matters to people. They're not interested of, what was the EBRT fractions you gave and those kind of things. No, no, no. First of all, it goes above people's head, even mine. But the point is, they are not interested in what we did. They want to hear whether what they did was okay or not. And if you convey it in those terms, hopefully that will be the answer to your question.
Yeah, thank you so much, sir, for the excellent answer. If there are no more questions, can we wind up the session, Rajalakshmi?
Yes, sir, we can.
Yeah, so thank you so much, sir, for the excellent presentation, and thank you all for the participation. Over to you, Rajalakshmi.